Connecticut Children.
Hi, folks.
Happy New Year, everybody.
New Year.
Adam, I believe your hair is getting longer than every day. Yeah, there's no way your wife's going for that.
That's Happy New Year.
Happy New Year.
Happy New Year.
Hello, everybody.
Hello.
How is
Hey,
everyone?
Julie, how are you? Matt, good morning. Good afternoon.
How's everybody?
Hello, everyone.
Hey, Henry. Happy New Year.
Henry.
Happy New Year to everyone. So we'll give everyone a couple of minutes to get back, and then we'll get started.
Sounds great. I think you had said 110, right?
Yep, because I'm gonna just give a little spiel, and then we should give way. So
Sounds great.
Is that up? You guys see it?
Yes.
Tamala Khamenei.
So Julie, I'll set up my screen really quickly. Before you. Yep. I just want to.
I guess we're each sharing our screen as we go, right?
Yep. Yep. So who else is on right now? Sharing the screen.
Did I actually see Ron on the list? Is Ron Barrett on from Israel?
Yep, he is.
Hey guys.
God help us all.
Oh, come on, Dave.
It's good to hear from you, my friend.
It's good to hear and see you. But when you're saying God save us all, you mean after, the Capitol Hill events or things like that?
Yes.
Wait, did something happen?
Whatever meaning you would like, my friend.
No, look, after suffering Israeli politics for the last years, it's so comforting to see that there's a crazier country than ours. Seriously. So thank you guys. We appreciate it.
When my Canadian friends text me and say, "Are you guys okay?" then we're in desperate times.
Apparently so. Apparently so.
All right. So I'll begin in a second. So I just wanted to give a little spiel about essentially the collaborative since the start of it last year. We started with 7 that you're seeing on your screen right now. That's where we started, and then I named it New PEC just for the lack, because I know it was not very creative at that time. So those were the original 7 that started, but now it has grown on to over 38 institutions. And that's thanks to all of you guys just for spreading the word. So I just want to take a time to thank each one of you just for participating and keep spreading the word, which has made this collaborative great. And it's something that that it went from a small idea to like now this innovative and collaborative. That's awesome. So I just want to thank all you guys for that. In terms of our attendance, I've been tracking. So this goes by just users. I know there's a couple, when some people log in, there's other people there, but this is just by the users I sign in. As you can see, we range around the 20 in terms for attendings in each meeting. There are sometimes that it goes over the 30s, but that's in the 20s is where it looks like we are on a weekly basis. We started in June, so it's been over 6 months now. We'd had 28 sessions. We started doing the CME and the MOC in November, and I think that's been going well. So I just want to make sure that everyone was finding that helpful. And core institutions, and by that I mean like the original 7, usually present on average every 2 months, which I've been trying to, as more people participate, been trying to give them more laps in between. And then the future goals that I sort of wanted to see was obviously continue to expand, get more people, increase the attendance. And then the other thing I was considering doing is planning a conference or workshop in 2022, as I think 2021 is going to be governed by COVID. But that's sort of like the future plans. And I wanted to see if there's any quick feedback, if there's anything you guys suggest that I can do better, or if there's any other ideas any other people had to make the collaborative better.
I think overall it's been really great and really great networking. I know that as a practitioner from a loan institution, having a bunch of people that can look at my scans and give me some opinions on what they think, I think that would be great. So I love that for that reason.
Ariana, go play with her. She wants you to chase her. Ari, throw the play catch with your sister, please. Remember what we learned yesterday? Ariana.
Okay. You want to play catch?
Yeah, I agree with Erica. I look forward to this session every week. I try to block off my schedule now. And I think even for fellow education, both PEM fellows and PEM POCUS fellows, this is just a wonderful venue to see very interesting cases and talk to people who really know what they're doing. So thank
Ellie,
you.
make
Thank
sure
you.
you're
Thank
playing
you.
too with sister, okay?
No, I agree with Antonio. It's not only just interesting cases, but even just everyday cases that I actually get other people's opinions and how everyone kind of handles even the everyday cases in their own shop. So Henry, applause. You're doing a fantastic job in kind of coordinating and assembling all these people. So hats off to you, except Antonio's hat, you know.
I've really enjoyed people sharing their particular interests too. Some of the more focused sessions where people talk about what they are working on in their shops and directions they're going. That I think has been an added benefit to the cases. So those are 2 things that I think have been wonderful from this opportunity to share amongst us.
Yeah, and then again, I thank everyone for those words, and then but like I said, I think every component here is what is collaborative, and this makes it so great. So I look forward to continue to doing it. If there's any sort of feedback you guys want increase more, just let me know. And today's session, I want to sort of recap 2020, and I sent you guys the, like a list of all the cases that were presented, so that way you guys can pick like your favorite ones. And after the voting started, so I gathered the top 5 of last year, and fortunately I was able to get all the presenters to be present so they can represent their cases. And then after that, I wanted to take a quick second. I hope that's okay that if after all the presentations are done, if you guys can send me a personal message through this, so you guys can give me a quick vote, so I can just basically pick like the favorite case of 2020. I think that would be a nice way to end, to begin the year, and then and sort of go on and hopefully make this more a better year. So the people that were selected, I'm going to share my screen again. Sorry,
just before you go forward, I just wanted to say, as an ultrasound fellow who's at a place that's primarily adult focused, these sessions have been great for me to get education on pediatrics focused ultrasounds, and just continue my growth as a PEM physician who's using ultrasound. And I'm sorry about before, I thought I was muted.
No, it's fine. But yep, so thank you again. So the top cases were presented. So this is in no reference to the number of votes that each individual's got, but essentially this is the order in which they'll be presented. So Julie will be presenting her case, then followed by Rahul, Erica, and Tasso, and lastly Tom at the end. And like I said, at the end, if you guys can just shoot me like a personal message through here, sort of which one is what's your favorite, so that we can tally up and then get a winner for this. I think it would be a nice, healthy competition to do. But that's pretty much for me. So Julie, I'll stop sharing so you can stop. You can start your case.
All right, just setting up. All right, can you all see it?
Yep.
Yes.
Great.
Yeah,
All
looks
right.
good.
Great. So the credit for this case actually goes to a colleague of mine for a great catch. So let's get started. So this is a 21-year-old gentleman presenting with hemoptysis, shortness of breath, and chest pain. He was actually treated several weeks prior for pneumonia, and now his cough is back and he noticed blood in his sputum. In triage, he was afebrile, heart rate was 108, blood pressure 113/81, breathing at 18, and satting 95%. So I'm just going to show you his EKG. So shows some sinus tachycardia, and to me the most striking thing is the RVH. We have some right axis deviation, the dominant R wave in V1 and the dominant S in V5. And anyone else struck by something? I'll go on to the chest X-ray. So here, just some scattered, faint, patchy areas of consolidation bilaterally with the right greater than left is how it was read. So let's use our ultrasound. So here's our peristernal lung axis. So some really striking flattening of the RV septum towards the LV. Here's the peristernal short axis, also showing some RV dilation, that septal deviation, and this is our classic D sign. In either pulmonary embolism or pulmonary hypertension, the septal abnormalities will first appear during diastole, but here we're seeing it throughout the cycle. And then here's our apical 4. We're seeing that right ventricle look greater in size than the left ventricle. And then another thing I want to point out is this McConnell sign, where we have this right ventricular free wall sort of akinesis
And we've lost her.
I think we lost Julie. I'll give her a minute and see if she comes back.
I'm back.
There she is.
All right, you all still with me?
Yes, go ahead. Julie.
Okay. So this poor 21-year-old had a BNP of 9,400. His troponin was 0.02. And I didn't actually see a D-dimer in there, and it was probably because it was pretty obvious what the next step would be. He had a massive PE on CAT scan. He actually failed thrombectomy and went for a pulmonary artery thromboendarterectomy. So interestingly, this kid's hypercoagulability workup was negative, and cardiology diagnosed him with chronic thromboembolic pulmonary hypertension. I'm not totally sure how this diagnosis was made through my chart review. One thing that did come up, especially talking with the folks in this group, was that this was on January 30th of 2020. So while we weren't aware that COVID was already infiltrating into our community, it very much was. So that's, one thought that that this might be. He's following with cardiology. I just thought I'd review, so here's our classic D sign, our RV greater than LV in our apical 4 with our McConnell sign. And then I just figured we could talk quickly about other POCUS findings to look for. The biggest things we're wondering in a case like this is this a PE or is it pulmonary hypertension? And certainly I know Erica has seen a case of congenital pulmonary hypertension leading to acute respiratory distress. So when we're looking on POCUS, there's no one sonographic finding that can distinguish chronic from acute causes of these findings of RV strain. Both will cause RV dilation and strain, but just some other things to look for. So one is the tricuspid regurg, so putting that color Doppler over the tricuspid valve and measuring the tricuspid regurg jet velocity using continuous wave Doppler. So basically, the higher the velocity, the more chronic the pulmonary hypertension is. And just think of it like the higher pressures over a period of time require remodeling of the RV. And so when that happens, you get those higher velocities. So the next thing is the thickness of the RV wall. So that can indicate chronicity. Might be helpful, but also not present in all patients with pulmonary hypertension. Another thing is looking at the TAPSE, the tricuspid annular plane systolic excursion. So that's using M mode, measuring the movement of the tricuspid annulus from diastole to systole along the long axis plane of the RV as it squeezes. So the lower the TAPSE, the more poor the RV squeeze is, the less it's moving along that axis. So less than 10 millimeters would be consistent with severe RV dysfunction. And then the last thing would be a dilated plethoric IVC. So that's all I have on this case. I'm interested in opening up the floor to any other thoughts or questions or comments you have.
I have a question from Matt, Julie.
Oh, can you read it? I can't see the chat right now.
Oh, sorry. So it said it would also add pulmonary artery acceleration time to that as well.
Oh, yeah.
Yeah, so that's his input.
All right, if there's no other thoughts or comments or questions, then I'll hand the baton over to Rahul for our next case.
Thank you, Julie.
Thank you. Thanks for having me.
Hey guys, can you hear me?
Yep.
Hey, just having a little technical issue. My computer froze and I had to switch over to a different computer. So sorry about that.
Can I ask Julie a quick question? Julie, it's Alicia. How are you?
Hi, Alicia.
How are you?
Good.
Good. I'm just curious because he's been followed now. At any point, did they do COVID antibody testing? I'm sure in January, March, April that was not
No.
available, but I'm just wondering
No.
even more recently.
I scoured the chart and I didn't see it. I've been like so disappointed when I looking for it.
Cool. Thank you.
Oh, sort of another interesting thing about this case that sort of complicates the picture entirely is that he, in his huge genetic workup, he also had a gene, a genetic predisposition to a dilated cardiomyopathy. And he happens to have two grandparents who died of what was concluded to be a heart attack at age 40. But the cardiologist felt that was unrelated to his PE.
I just had a question. I noticed in the echo that he had that hyperechoic, that very hyperdense bright stripe on his septum. Did he get a cardiac MRI by chance?
You know what? I didn't see one, but that doesn't mean it wasn't there. I'm gonna check again.
I only asked because I recently, I just had a patient who had a exercise-induced syncope, and she came in VTAC, and she self-corrected, but her my bedside echo, she had this really hyperdense stripe in her septum. I called the cardiologist to come do the echo as well because I'm still a little young, and he said the same thing. We transferred her to Cohen's. She got a cardiac MRI, and she ended up having all that hyperdense white stripe was actually fat and scar tissue, and she had a arrhythmogenic right ventricle. Was diagnosed with that.
Wow, it's a really interesting case.
Yeah.
Rahul, let us know when you're ready to go.
I'm good to go. Sorry about that, guys. And thanks, Julie.
Okay.
All right. So I'm going to present a case that I had the pleasure of presenting a couple of months ago. And since I've made some edits to the presentation as well, after getting some feedback and some additional information from our last time it was presented at PPAC. So briefly, I'll sort of present the case the way I had earlier, but then add in those sort of caveats as we go along. And this is a respiratory distress case in a neonate. Briefly, this is are my slides moving along with me? Yeah, you guys can see the next slide.
Yes.
Perfect. All right, so we have a 2-week-old kiddo. He came into our EDs ex-full term, born by vaginal delivery for respiratory distress at home. And mom and dad were sort of flippant about everything. They felt like the kid had been breathing fine. They, I guess, had noticed that the grandparents had visited the family a little bit ago, and the grandparents were really worried about the work of breathing, and that's what really brought them over to the ED. Felt like maybe it was a little bit worse today, and felt like it was associated with feeds, but again, family, like the parents at bedside were pretty underwhelmed, and really were just there to humor their grandparents, the kids' grandparents. The kid had regained birth weight, no congenital history of cardiac defects in the family, and no COVID exposures that were known, and no real birth history to make note of either. So our triage vital signs were pretty reassuring overall. I mean, the respiratory rate's borderline, but again, looked fine. Heart rate and blood pressure looked okay too. And so looking at the kid from the door, I had this child when the kid came in, his arms, the skin was mild, increased work of breathing with a small amount of subcostal retractions, but nothing beyond that that I appreciated then. So I was in the middle of evaluating a different patient, and between the time that I'd filed the child and was on the way to coming back, Dr. Chikaiza was already in the room because the patient had desaturated into the 80s, and nursing had called out for additional help. The kid now had worsening work of breathing and tachypnea, but there was no evidence of cyanosis, no apnea. Saturations were in the high 90s with a little bit of supplemental oxygen and suction. Listening to the kid, maybe there were some decreased breath sounds at the right base, but no crackles, no wheeze, and the kid was brought over to our resuscitation room, and we plan to initiate a septic workup and to get some additional imaging at that point. But before we were waiting for radiology, we decided to apply POCUS and see what we could find. Largely, we were looking at this point for a cardiac defect and wanted to assess for heart squeeze and make sure that was looking okay. And so I just remember, trying to get a good cardiac view on this child, and I was struggling to do that. I felt like there was some sort of consolidation or some sort of hepatization that was blocking me from getting a good view. Ultimately, we were able to get some decent views of the heart. Let's see. But it was challenging. So we ultimately did get a decent view of good squeeze, but as we fanned through the heart, it was just harder than usual, I thought, to get good views. So we started looking at the lungs as well. And, scanning through the lungs, we saw what looked like maybe this was like a consolidation or some sort of extra tissue around near the heart, but on the left upper side of this child's, the left upper lobe. And so we scanned a little bit more purposefully, further characterized it, and we saw them on this side. At the time, we were concerned mostly for some sort of mediastinal mass. This again is on the left upper lobe. And again, looking at the left upper lobe. I'll play that one more time. We moved over to the right side as well, and we didn't see anything there to make note of. But we were concerned at this point of some sort of left upper lobe process. So before I continue, I think one thing that last time I had this talk, there was a good conversation, I think brought up by Dr. Riera and Dr. Chen about the possibility of this being thymus rather than consolidation. And I think that's a good point. And I did some additional literature review about this that I wanted to share with you guys and sort of discuss this a little bit further, because I do agree that this likely was thymus rather than consolidation. And I'll come to the punchline for the story anyway in a few moments, just because it is a very interesting case and not something I've ever seen present to the ED. But before I continue, just because the focus of this case is largely on what I had demonstrated on point of care ultrasound, I want to clarify that some of the differences between consolidation and thymus. So there was a relatively recent 2018 paper published in Ultrasound of Emergency Medicine that sort of further discussed the differences between lung consolidation and normal thymus, indicating that this is not the first time this has sort of been confused with one another. And they've drawn out a few different images of what thymus would look like compared to a consolidation. And they have several clips and several images that they include in that paper that I thought were really helpful to comparing to the images that I took myself. So here, I'm just going to show those images, and just so you can further grasp potentially the differences between thymus and consolidation, because some of it can be subtle. Here they're highlighting a couple of different images of thymus on point of care ultrasound with corresponding X-ray as well. And then they point out areas of a consolidative pneumonia or any sort of consolidative process, where they point out air bronchograms that seem much more hyperechoic than the thymus does. And they also brought the idea of using color flow Doppler, where the thymus is very hypovascular, whereas a consolidative pneumonia would still sort of expect to see vascular markings associated with that lung tissue. We did not apply color Doppler here, which I think would have been, certainly an interesting thing to have looked at, but we we did not do that in our point of care ultrasound. And then, just a breakdown between thymus and consolidation, just as I discussed very briefly, both of them are hypoechoic, but the consolidation with some linear, like additional hyperechoes associated with trapped air. The use of color Doppler, again, to look for branching vascular patterns in a consolidation versus the absence of that on the thymus. And then I think the things to look at really particularly for this patient was how well defined the borders were and how it molded really around the heart, which would be more suggestive of thymus, as well as the internal structures not moving with respirations. So again, if we look at this, I think we see really well-defined borders that are molding to underlying structures. I'm not seeing huge hyperechoic areas within the area of question in the first place. And the internal structures don't seem to be moving out of proportion with respirations. So I think ultimately what we saw, I agree, is probably thymus, but still an interesting case, which I'll come back to now. So we got a chest x-ray as well. Here is what the x-ray revealed. And, looking at this, especially if you're looking at it from the, tiny x-ray monitor, you might I think it's easy to sort of potentially be fooled and look at the right side of the lung and think that's the abnormal side. And maybe there's a pneumothorax here. You can see some vascular markings, I think here, but I think if you're in the heat of the moment and if you're looking at it from a smaller screen, you might be inclined to say, hey, I heard decreased breath sounds on the right, and now I'm concerned about a pneumothorax here. But in reality, it is not a pneumothorax. Instead, this was concerned of congenital pulmonary emphysema or congenital lobar emphysema on the right side, so that right lung is so hyperinflated with air that it's pushing the left lung considerably and creating a mass effect. We got a blood gas at the time as well, and was concerning of 0.5. And a huge learning point for us really was learning that, we at that point, we spoke with surgery and anesthesia, which fortunately were around the department. They looked at the images and it brought up the very real concern of intubating this patient largely would be very potentially dangerous because it would ultimately need a chest tube. And by intubating, we would be providing additional positive pressure into this already over-distended right lung. And instead, really what this patient needed was a lobectomy, but a chest tube as well. So this patient was brought emergently to the operating room. And there, they were able to resect this part of the right upper lobe. And the child tolerated that procedure quite well and was able to go home several days later. And ultimately diagnosed after looking at the pathology of unknown origin in terms of why this patient had congenital lobar emphysema. Oftentimes there's some abnormality or something you may be able to notice in the bronchus or bronchial cartilage, but nothing that they were able to make note of on the pathology report. Very briefly, just, it's a rare developmental malformation. 50% of the time, as with this patient, it's idiopathic. So here on this X-ray, it's the left side that has the distension and pushing with a mass effect over on the right. So the left upper lobe, like the second image I just showed, not our patient, but the image. Prognosis. Just a reminder, not to needle decompress, like oftentimes with proper intubation.
Henry, is it me or him?
It's him, because I thought it was me for a minute. I was about
Got
to
you
move.
out of bed.
I was like, what's going on? Yeah, it's him. So sorry about that. I think everyone's having internet issues today.
Only when they start presenting.
I know. Maybe they're getting too nervous. It's too nervous. I'll give him a minute, and I think he was practically done with the case anyway. So,
So you're calling it performance issues?
Yeah. I think he's texting me right now, so let me make sure. See. Yeah, he got kicked off apparently, so not sure what happened there. Any feedback regarding that? I was involved in that case. Oh, there he is.
Hey guys, sorry. I don't know. I get kicked off of my. I don't know what's going on. Were you guys able to see the end of the presentation though? Hello?
Yep. I think.
Yeah, you were.
Yeah. So I was asking just for feedback if there's anyone else that had any questions regarding the case or anything else.
When you say that he was brought emergently to the operating room, like how emergently did he get transferred? I as an attending, I guess would have a really hard time sitting on my hands with that gas. So I'm just curious as to like what was the background like noise and the discussion in the critical care room at that time?
Yeah, it's a great question. Very active. So surgery and anesthesia came down and we were preparing to intubate and they're like, do not intubate this patient. We're going to take him to the OR essentially. And, I think it's interesting. We had deliberated potentially doing a CT scan just for surgery didn't really necessarily need the CT scan, but it was a question of whether or not they wanted to get formal, a definitive diagnosis with a CT scan. And as that conversation was happening with the father and our surgery attending, the patient started desatting into the 70s. And so the father was like, I don't know, do I want to get the CT or go to the OR? Maybe I don't need this procedure. And then like saw the kid desatting, was like, forget it, just take him to the OR. And he went upstairs. So yeah, it was pretty, very acutely essentially went upstairs.
Did they intubate him there? Like, how did they intubate him up there? Like, what did they do up there to be any different?
So, yeah, so you can go ahead, Rahul, if you want to answer that.
I think it's just in the setting of knowing that they're going to place a chest tube and then resect as they're like intubating. I think that the idea is that they just want to be completely prepared to immediately place a chest tube and resect the affected lung.
And then when I had a discussion with the pediatric surgeon, he said essentially there's been some cases that basically you have to be ready to do an open thoracotomy, worst case scenario. So that's why it's better to be done in the OR with them. And so that way, if he has to do it, I guess he's seen a couple of these cases and he said like half of them have gone into where he had to like switch them to open thoracotomies in the OR. So he scared me. I was like, yep, I'm gonna always second guess myself when I see a pneumothorax in X-ray.
And how is the airway being managed just in the meanwhile, like as the kid is going up to the OR?
He was just managed, I believe, the entire time on nasal cannula. We didn't want to introduce any additional positive pressure, and his saturations prior to that desaturation event were fine. He remained like tachypnic into like I would say 50s to 60s, but his saturations did improve with just a couple of liters. His work of breathing still was there, so it was still pretty moderate, at least moderate work of breathing during his ED course.
Hey, thanks. That was a really interesting case. I have a question about the thymus. Which views did you see the thymus on? Were you seeing it like both anteriorly and posteriorly? I'm just curious. I have run into that.
Yeah, just anteriorly. From what I recall, Dr. Shikazi, you can correct me.
Or consolidation.
Yeah,
okay.
I believe all the views. Yep, I believe all the views that were there, and yes, they were all anterior views.
Perfect. Yeah, that's where I've seen it. But I was just curious position of the thymus can be pretty variable.
Mm-hmm.
Any other questions or comments? So we can move on to the next case.
Thanks, guys. Sorry for all the technical issues.
No problem. All right. Thanks.
All right, I think I'm up.
Yep. You're up, Erica. Go ahead.
Share my screen. Okay. So I hate to follow two amazing cases like that. If I'd known it was going to be a competition, Henry, I would have done the Lei Chen trick of bringing Dove dark chocolate and milk chocolate and throwing it at people when they answer the question correctly.
Hey, that's my secret.
Well, I can't, if I'd known, I've been sadly poorly prepared for this competition. So I'm just gonna have to settle for the plain old boring slide model. So case 3, this is a case of a 6-month-old baby who came to our ED with kind of 1 day of intermittent abdominal pain. Baby had been, relatively well before that, started developing these episodes of screaming, had some mild URI symptoms, and in the ED was having the classic intermittent abdominal pain that made people think of intussusception, just given the patient's age and his physical exam findings. So I wasn't in the ED at the time when this diagnosis was made. Otherwise, there would have been point of care images, but this child went to radiology first, and they diagnosed an ileocolic intussusception, and you can see it there in the short axis and in the long axis. And the patient underwent a successful air enema reduction. So this was from a couple of years ago, and still at the time, they were, I guess there's a lot of kind of variation in how people manage this at different centers, but in our center, it had been that we used to admit them overnight. Now we're admitting them to our OBS unit on our step down unit here in the ED for overnight observation after successful air enema reduction. So this patient underwent successful air enema reduction, was looking great. Symptoms had mostly resolved, and they admitted to our CDU overnight. That's our clinical decision unit. They admitted them overnight and wanted to watch. So I was the overnight attending, and I got called in the middle of the night to say that this child was having intermittent screaming episodes, and they were concerned that maybe he was re-intussuscepting. So I was like, great, I'm gonna go grab my ultrasound. I'm gonna see what this looks like. And so I went to the bedside, and my first, Adam Sivitz always taught me, like, make sure you always look at a good right lower quadrant first and see if you can diagnose normal anatomy. And if you diagnose normal anatomy in the right lower quadrant, it's probably not intussusception. So I'm including this for you, Adam, if you're still there. This is what the right lower quadrant looks like, and I'm going to leave it at that. And then I scanned around and this, and this is actually in the right upper quadrant. And the only thing that I want to say about this case, because even when I was prepping to do this case again, every time I look at this, I'm like, man, this looks just like an intussusception. And for the people who have been here, heard this talk before, I would love to know how many people here think this is intussusception. Anyone? Is this intussusception or not? It's a loaded question.
Just
limited views right now. Yes, right now, yeah, without any further images, though that's exactly what we would like to see. But yes,
it looks like intussusception, right? So remember,
sort of like oblique-ish, though, not like a perfect transverse.
I'm going to say that
long
this
to
is
oblique.
your probe. This is your probe. This is my trusty fake probe. my probe was like this in the right upper quadrant. So the axis of this image is not typical for intussusception in order to get this image. So I'm just going to leave it at that. So that's the one thing when I was looking at this, scanning it over and over, I was like, the weird thing is that normally my probe is in transverse in the right upper quadrant to get that kind of view. And this time it was longitudinal and I just couldn't make any sense of it. So remember, it's the middle of the night. We have a relationship with radiology where we just do our own thing. Each person does their own thing and nobody says anything. Don't ask, don't tell. And so it's one of those things where if you're going to call in the radiologist from home to do an air enema reduction, you've got to be pretty darn sure of what you're looking at. So I got a little excited with this scan because I was like, this looks like intussusception. And I was still scanning. The timestamp on this, I was literally scanning this patient for 10 minutes at least, trying to get the proper image in the right plane, and I could not get it in the right plane to fit with what I'm used to for intussusception. So you can see in the top left of the screen there, you can see the tip of the liver. So you know it, I'm kind of like in a longitudinal view there. But it really looks like intussusception. So I woke up the radiologist in the middle of the night and said, you know, this kid has intussusception. And he said to me, well, get the comprehensive scan and I will come in. And he was an older radiologist near the end of his career, who's getting ready to retire. And he had poor sleep anyway. So it was very common for us to see reads from the pediatric radiologist at like 4 o'clock in the morning because he happened to be up. So it wasn't that big a deal, but I did wake up the radiologist over this, and the comprehensive scan showed that there was no intussusception. So what happened? What happened was that this is actually ileocecal valve edema post intussusception reduction. And this is the picture that he got. The radiologist ended up coming in for this anyway and scanned around and said, you scanned the ileocecal valve and what you were scanning was edema of the bowel with ileocecal valve edema. And so lesson learned for me on this case was really, number one, if it's, you know, like we're so used to pattern recognition, the thing that wasn't fitting for me with this was the plane of my probe. And so, you know, for that, I think I should pay attention to that a little bit more. But also what I'm going to start doing is scanning more kids post intussusception reduction just to see what it looks like. Because I think I've seen bowel edema now a couple of times and it does look pretty impressive sometimes. But even on preparing for this talk, I'm looking at these images again and I'm telling you, like, it really looks like intussusception. And even this picture itself, when you look at it, you know, I think in the clinical context, you know, the radiologists do have a benefit, like they're removed from the clinical context so they can look at it and say, you know, oh yeah, that's clearly ileocecal valve. But if you have a, you know, intermittently crying 6-month-old post air enema reduction and you're getting miserable images because the kid's screaming while you're doing the scan, it's very easy to jump to that conclusion. Oh, look, it's an intussusception. So no harm done in the end. Our radiologist was very nice about it. It did not set me back 5 years in terms of my credibility, maybe just 1 or 2 years instead. But I wanted to present this one. I saved it for all of you for probably 2 years so that I could present it to a group of people that are experienced in doing this. That's all I got.
Erica, I have to tell you, there's a difference between what you're showing us now and your original clips, right? This is, you know, I got to tell you, I think you had to have captured it in the beginning and maybe it's self-reduced by the time it got to radiology. I don't know, you know what I'm saying? Like they're clearly different. And the only way I can tell you is that by size, right? This thing is at
big,
least,
right?
This is at least 4.5 centimeters. What you showed me in the end is less than 2. So it's clearly, you know, I'm curious, did the radiologist see these clips or your clips?
I'm not at a stage in our institution where I can do that yet. Maybe like that was 2.5 years ago. And definitely we were not at that stage where we could I could say, hey, do you want to look at my images? Because the answer was going to be no, I don't care what your images are. Now maybe I can pick one radiologist maybe who's willing to look at my images. But the reason I'd saved it for all of you is because this is the forum that I need to kind of review these images. This one, that first one that I showed, this one, I mean, even looking at it now, but I can't reconcile the plane of the probe on that because I was scanning for a long time. I don't normally scan for that long to get an image that looks like that.
I agree with Dave. Part of me wants to feel like the plane of your probe isn't like the deal breaker here.
Yeah.
You know, we have had a case where POCUS identified a fairly clear sort of textbook target, size, features, the whole thing, and reviewed by an attending radiologist that said, yeah, that's intussusception, let me come in from home, sort of the same deal. And then on post, that ileocolic intussusception had spontaneously reduced, and there were some post-inflammatory changes, primarily like an ileitis that was seen by radiology ultrasound. So not impossible, kind of really interesting to think about.
It's just very high up though, because it's like right up in the right upper quadrant. Yeah. So I would imagine that to self-reduce that quickly, like within the hour, is that like, I would also find that part hard to believe, right? Because it was, I mean, his whole ascending colon would have to have been intussuscepted there.
So I think it's a great idea that we should totally be rescanning these kids when they come back from radiology to see what they look like when they're de-intussuscepted.
Yeah.
And I feel like the imaging plane is also very different. So we're normally looking at it in a transverse plane to identify it as intussusception. On those post-reduction images, I like looking at it in like a long axis, because then, you know, I think the comment of how big it looks at post, it's the colon still looks big, and that IC valve just looks like these really big thickened lips, and that terminal ileum also looks thickened. So I think if you had it rotated in our normal plane, it looks like this. It looks like it's totally positive. But in long axis, it's short, like the small bowel intussusceptions are. And I think it's that, you know, the fact that it's obviously short, that it's not like a re-intussusception, different than like a big ileocolic that's coming up into that right upper quadrant, where it's still going to be, you know, normal targetoid appearance, but then also has a long length to it that we can trace out.
Yeah.
But this should like totally be in our wheelhouse, identifying both, you know, the pre and the post imaging.
Yeah.
I agree. Adam, also Erica, sorry I had to step away, but I don't know if anyone mentioned that. Sometimes, I mean, you're already at 6 centimeters on the linear probe. You may want to then at this point go to like a curvilinear, you know, just to give you that breadth of, and it's like a wide angle view, and it gives you a better sense, because you're trying to cram all this into a very narrow scope. Because as you know, as the depth gets bigger, your window gets more narrow, just because your probe is trying to do more. But sometimes, like the Zanari has a great 3.9 curvilinear, and you're going to be able to see this a lot better and be able to kind of adjust your eyes to what you're seeing. Because I don't know, this is clearly, I don't know,
right?
I don't think you have to sell it too much to this group.
I don't know. I feel this was
yeah, I was
humbling
actually
for
just
me.
going to suggest that too.
Yeah, increase the depth a little bit on that.
Yeah, I had, it was actually a small bowel. Yeah, I had a small bowel intussusception the other day that was just so swollen. It needed surgical reduction that I couldn't get the whole depth of it with the linear probe, and switched to the probe and got beautiful views with it. But that's where radiology has a bit of advantage with their probes too, that have a wider view.
Yeah, certainly super interesting. And I'm gonna, you know, I feel like we should all be scanning these after, just so that we can get a good idea of what's going on and what
Erica,
it looks like.
The urban myth now will be from this point on, I'm going to say, I know a PEM person who self-reduced an intussusception via point of care ultrasound.
Case report, you and me, Dave. All right, that's all I got, guys. Thanks for the
Thanks, Erica.
discussion.
Thanks. And then for Jensen's time, just because I don't want to run over too much. Tasso, you want to take it away really quickly?
Yes, sir. Let me share my screen. As a healthy competitor, I don't know who made this front slide.
Well, it made me feel great.
You guys see it?
We're gonna have to get Henry back. Don't worry.
Oh my God. So the resident
Right.
look at the patient. Oh my God. You don't want to do anything like that.
People here.
Very welcome. And I felt very relaxed.
All right, I'll go through this quick. So we had a 14-year-old male that was heat struck, multi-trauma, that was transferred from outside hospital. Initial GCS at that time was around 8 or 9, but he was maintaining his airway. He was alert, so he wasn't intubated. Sent to us. On us, his GCS was 14. He had pretty generalized abdominal tenderness, more so on the left and on the right, and some mild shortness of breath. And on physical exam, he did have some decreased breath sounds on the left. So I did a fast, and this is on the right side. And if you guys remember the case, clearly what we see here is here, and then we have a little mirroring. We have the liver, and we see no fluid above that diaphragm in that, and the kidney, for the most part, looks pretty normal. Morrison's pouch, we don't necessarily see fluid. We do see a little edge artifact that goes all the way down from one of the vessels, but it's not fluid per se. And then I proceed on the left side. The left side just looks a little more funkier than the right. And here, I can't get a good view of the full diaphragm. Did I go to the next slide? No. I can't get a good view of the whole diaphragm, especially down here. It kind of gets cut off. And then as I play through it, we see there's a little hypoanechoic areas in the spleen, which should suggest injury, along with anechoic areas right above the diaphragm over there. And then we start scanning through, and here above the diaphragm, it looks a little weird. I don't see any lung tissue. And then we go all the way down, we see that splenic lac. But here I'm above the diaphragm, and there's really no lung tissue that I'm seeing. I'm scanning just to try to get a little more definitive of what's going on. And then we get over here, and does anyone see, we see what's going on over there? Almost looks like bowel, right? It's like peristalsing, and that's within the chest wall. That is clearly above the diaphragm. And here we see a little free fluid on the inferior pole of the spleen, which is depicted here, not getting such a crisp diaphragm on the lower aspect of this image. And the same thing here, we just see a lot of schmutz in the cavity, and we see that peristalsing bowel. Don't see any kind of lung tissue at all. And here I'm axillary, so I'm really high up in the lung, and I really can't see. I still can't see any lung tissue. and I just completed the fast here. He really didn't have any free fluid in the posterior to the bladder. And the same thing with the cardiac view. It looks like he had good squeeze. And the same thing here. And this is the initial x-ray, and we see that bubble almost going right into the chest cavity. Typically, right, the right hemidiaphragm is higher than the left, and this time it's clearly not the case. I've never seen anything like this before, so this was definitely very interesting for me, especially confirming with the peristalsis in the bowel in that chest cavity. And I was looking, and Michael Blevas had an article, Bedside Emergency Ultrasonographic Diagnosis of Diaphragmatic Rupture and Blunt Abdominal Trauma, which I wish I would have read beforehand, because here he uses M mode, and I could have used M mode on that right side to see the movement of the diaphragm as depicted on the right, whereas opposed to the left, if you use the M mode on that side, you really don't see any movement since the diaphragm ruptured. That would have been nice to have added to the scans to more objectify that truly there was a rupture there. And that's it. Sorry to go quick, but since we're running out of time, that's all I got.
No, thank you. That's good. That's always going to be. I've meant to email you to send me those clips, just because I want.
Yeah, I'll send you the presentation.
Yeah, that'd be awesome. And then lastly, and not least, Tom Kennedy will present in the last one, and then after that, if you guys can send me a quick personal message, that'd be awesome. But Tom, take it away.
Oh yeah, thank you. Let me just share my screen. Hold on. Are you guys able to see it?
Yep.
Okay. All right, so a lot of great cases to follow. This one that I have, this was a 5-week-old female. She'd been born full term. She didn't have any significant past medical history. And she was coming in with 12 days of left distal thigh swelling and also pain with movement of the left knee. She didn't have any associated symptoms, no fever, no rash. And during the course of this condition, in the first week, she'd been seen by 2 pediatricians who both had reassured the mother that they didn't see anything concerning and had sent her home. But on the day of presentation to our emergency department, she was seen by a 3rd pediatrician who decided to send a complete blood count. And that revealed a peripheral white blood cell count in the 20s with mostly neutrophils. And so they sent the patient with the mother to our emergency department. And when they first got there, you can see the vital signs for this patient's age were all within normal limits. And the patient had gotten there about 30 minutes before me. She'd been seen by one of my colleagues. But by the time I saw her, she was awake, alert, interactive. She looked as happy as could be. And the only significant findings were musculoskeletal findings, which were that the distal left thigh was very swollen and very indurated, but there was no fluctuance that you could appreciate. And the left knee, she was holding it in a flexed position. And whenever you would try to extend the knee, she would start to cry and she would try to resist you. And so the first doctor that saw her had ordered laboratory tests as well as x-rays and a radiology department ultrasound study to be done. And this slide here, this just shows the abnormal findings on the laboratory tests that were done. So her peripheral count was, white count was 20.6, and the platelets were elevated in the 600s. The CRP, we used the high sensitivity CRP, that was 72, and pro-count was up a 0.8, and the ESR was up to 115. The electrolytes showed that she was a little hyponatremic at 131, and her BUN and creatinine were significantly elevated for her age at 35 and 0.76. This was the knee x-ray that was done. And the radiology department interpreted these radiographs as showing no abnormalities. And these were femur x-rays that were done as well. And these were interpreted as showing swelling of the soft tissues of the distal left thigh. Before the patient went up to the radiology suite for their ultrasound, I took our ED ultrasound machine and went in there and got a few pictures. And what this clip here, this is using the linear transducer, and we're at the distal aspect of the left thigh in longitudinal orientation. And to take a still image of this, what you're seeing here, so this is the distal diaphysis and metaphysis of the femur. And here's the epiphysis. And then you see this mass above it, right here. And so this is just fanning through that mass. And then we put color on it as well. And you can see that there's no significant blood flow within it. And just to get some measurements, you can see measurements 1 and 2 here are 2.8 and 1.1 centimeters. And this is changing the orientation of the transducer to the transverse plane. And you see the femur here. And then as we scan from distal to proximal, you see the cross-section of this mass. And here's a still image of it. This underestimates the real size of the diameter, but you can see it's over 3 centimeters in its width. And unfortunately, I didn't, before they took her up to the radiology suite, I didn't compare it to the normal side, but this was a side-by-side comparison that was done by the radiology department. And on the left side, you can see the normal right distal thigh, and on the left side is the affected side. And so for people who weren't present when I first presented this case, does anyone have any thoughts of what this might be or what you would do next with this patient? This, it ended up
It
being—
doesn't look like it's bony in origin, though.
What did you say?
I said it doesn't look bony in origin, like it's coming from the bone. Maybe some kind of muscular mass.
I thought I was seeing a good amount of posterior enhancement behind it, so possibly fluid filled, maybe, and with the white chem, maybe an abscess.
Right, exactly. So there was posterior enhancement, and this was interpreted by the radiology department initially as being a distal thigh abscess. And so I had this, we had this well-appearing afebrile baby with a distal thigh abscess of unclear etiology, and it's very large in comparison, to her small little leg. And so we decided to go ahead and do a full septic workup on this patient. And her lumbar puncture, it didn't show any signs of meningitis, but her urinalysis showed over 100 white blood cells with bacteria and large leukesterase. And ultimately, her urine culture ended up growing over 100,000 E. coli. And this patient, we started her on ceftriaxone, and then other services recommended adding vancomycin as well. And while she was hospitalized, she had an MRI done the next day that was interpreted as a large abscess surrounding the distal femur with probable extension into the knee joint. And these are some images of that MRI that was done. And you can see it has this teardrop shape where, to me, it looks like it's coming from the knee joints. And this is it in cross section. And you can see it really wraps around the entire femur almost. And so this patient, she ended up getting taken to the operating room, and she, by the orthopedic department, she had an I&D performed of this distal thigh abscess, as well as having her left knee joint washed out. And both the abscess and the knee joint fluid cultures grew E. coli. And so the thought is that she had an afebrile UTI during this time period that resulted in bacteremia and seeding of the left lower extremity. The orthopedic doctor that took care of her thinks that this was an abscess that then secondarily violated the knee joints. But the radiologist I talked to thinks that it's more likely that it began in the knee joints and came out and then turned into this large abscess, which I think to me makes more sense because of that teardrop appearance that you saw on the MRI and also on the ultrasound. But she did well. Everything resolved with this operative intervention and the courses of antibiotics. And because it was such a significant infection without any fever, she was seen by allergy and immunology. And so far, the workup's not complete yet, but so far it hasn't shown any evidence of an immunodeficiency. So it just, it really makes you respect these kids less than 2 months. They can have some significant stuff even without fever. Does anyone have any questions about this case or any thoughts?
I mean, I've been commenting in the chat. This just seems so surprising to me that it's that large and clinically it didn't look like an abscess. You know, you'd think that if there was such an extensively sized abscess, there would be surrounding erythema, warmth, you know, all of those classic signs, even if it's a deeper abscess. I mean, how deep can it be in a baby's thigh, you know?
Right.
Surprising.
Yeah, I expected her immunodeficiency workup to show something, but so far, no. All right, guys, thanks for the opportunity to present this again.
Thanks, Tom. That was a great case. Always, you know, no matter times I hear it, I think it's how unique it is, and a very classic presentation of UTI, as Will said. So, thanks again for presenting. If everyone can send me their votes really quickly through the chat, that way I can quickly do the math really quickly. That'll be great. So if everyone can hold in suspense for 1 or 2 minutes, that'd be great. Okay, a couple more votes, and I think I'll have it. Just give me one. All right, so based on the comments you guys gave me, I just want to check if someone sent me. It is, the winner will be, this works out for me. Tasso. So Tasso, I'm pretty sure this is going to help your confidence already, since it's very, you know,
thanks, guys.
It's going to add to your, I think you can include that in your beginning page now, so that I think that would be great. But I wanted to thank everyone again for participating And those were great cases. I think it's summarized well. Then that's why I truly enjoy doing this, because I think I learned more. So thank you again for everyone. And sorry for running a little late. And as I send you in the email, there's also a chance for the second presentation that from Cohen's. If you guys want to join, the link is on the email. But otherwise, thank you again, everyone, for participating. And I'll see you guys next week. If anyone else has any comments, otherwise, we'll see everyone next week.
Happy New Year, everyone.
Nice job as always. Thank you. Bye-bye.
Thanks, everyone. Happy New Year.
No.